Yes.
Hello, Dr. Martlew. Can you see and hear me as we restart?
Yes, yeah.
Good.
Yep.
I want to move on, Dr. Martlew, to the hepatitis C look back in Liverpool. In your statement, you say you would have preferred that the look back had taken place in 1991 rather than 1995. Can you explain for us why that was?
Well, it would have been easier probably to do at the outset, nearer the first screening run, I think. And the only downside of doing it, of course, is that you'd have to tell the recipients that they got hepatitis C, and apart from, lifestyle modification, at that time there was no treatment. I think that's why it wasn't done. But I'm sort of familiar with the process from the HIV screening, or HCLV3 as it was then.
But from your perspective, I think I've understood your statement as indicating that your view was that it should have been done in 1991 when the records were perhaps a bit better and recipients had the opportunity to receive advice about alcohol, diet, etc.
Yes. Yeah.
Where we pick up then with you, Dr. Martlew, is in the Northern Zone Audit Group in the 12th of November 1996, NHBT 0036440. You were initially, at least, responsible for the hepatitis C look back in Liverpool, is that right?
Yes, well, I was continuing to work there full time.
And what we see at the bottom of this document, this set of minutes, is that you presented a review of the HCV look back in the Northern Zone, and you had summary overheads that were attached. And we're going to just look at those. If we could turn on to page 6, please. The overview that you provided to the meeting had this: donations identified by centres in relation to the LBF1 forms, and in Mersey and North Wales 463 LBF forms had been sent, which equated to 0.016% of the population. And we see an NB at the bottom of the page, most centres records from 1981 only. If centres records were only from 1981, what did that mean in relation to the look-back process?
Well, it probably implied that centres have been adopting a policy of keeping records for 10 or 15 years, and it would mean there would be, presumably historically, people before 1981 who could potentially have been infected, because the time between contracting hepatitis C and starting to present with symptoms of chronic hepatitis C can be a very long time.
So is this relating to a donation that was given in 1981? Was it the transfusion centre records that were only available from 1981?
Yes.
And so you could say a donor is identified as hepatitis C positive. You could go back on their donations all the way back, but at 1981 the trail would stop.
Yes. And I can't remember, to tell you the truth, whether it was for all 6 centres or whether that was the shortest time that one centre kept them, if you know what I mean.
Then if we go to the next page, we have a table dealing with hospital data and the fate of donations. We can see in relation to Mersey and North Wales the 463 LBF1 forms that were sent, of which 410 were returned, giving your bottom number 53 LBF1 outstanding. Then we have 147 record lost, 126 patient dead, and 60 patient alive. On my calculation, that gives a total of 333. Given that 410 had been returned, do you have any insight into what had happened about the other 87 forms?
I'm afraid I don't. No, I don't, because they'd be covered in the outstanding.
Then if we go over the page, we have the follow-up in general practice, the LBF2 forms.
Just on that, 333 from 410 is 77, isn't it?
Indeed, apologies, sir. That was my arithmetic that was.
We just need to correct. But the point's the same. It doesn't much matter, but it's just in case anyone's watching it, and it needs to be right. I suppose.
Indeed, 77 forms are not accounted for in that table.
Together with the ones which haven't been returned.
Indeed. So there's 77 that just don't appear in the table, and 53 where the LBF1 form is still outstanding.
Yes.
Then there is this next page follow-up in general practice, LBF2 forms, where we see 71 have been sent, 69 have been returned, and 2 are outstanding. Are these... How does this fit with the LBF1 forms? What's the difference between an LBF1 form and an LBF2 form?
Well, the recommendation by the department for the follow-up, and I think it was consistent for all 3 lookbacks, is that you should first approach the patient's family doctor to see if they want to speak to the patient about this and arrange the testing before getting in touch with them. And then the specialist who prescribed the blood in secondary care is also given an option before they are seen by somebody from a blood centre. So that would be informing the GP and asking the GP if they want to follow the patient up or whether they would prefer a specialist to do it.
So was this in addition to the 463 LBF1 forms or subsumed within it?
I'm just wondering. I would have thought you've got the LBF1 forms back and then started writing to the GPs of the patients who were alive.
So it would be...
The LBF1 forms
Sorry, go
just
on.
tell you, what the destination of the donation was, so you could get on with it.
We then have the next page, page 9, please, which sets out who was doing what was termed counselling of the recipients in North Wales, Mersey, North Wales, 5 by a GP, 17 by non-NBS consultant, and 38 by the NBS consultant. And then if we go on to page 10, we have the results of the Hcv follow-up investigations in Mersey and North Wales. Hcv antibody negative 24, Hcv antibody positive PCR negative 5, Hcv antibody positive PCR positive 29, giving a total of 58, with 2 patients who had declined the test. Is that right?
Yeah, yes.
Again, if we go back to our hospital data, that appears to marry up with the number of patients that were identified through the hospital data of 60. If we can...
That's right, it's aligned.
Yeah. But yeah. And then if we go on to the next page, page 11, we have, again, clinical outcome. 32 were referred, plus 2 who declined referral to a specialist. Mm-hmm. 26 for an outpatient visit, 11 with abnormal LFT results, 9 identified as HCV histology, and 6 receiving alpha interferon.
Yes.
And then if we just go back to page 2, which is the continuation of your presentation to the meeting in 1996, we see that you say this: it was apparent that the number of implicated donations identified did not correlate with the population served by each centre. There was a variable capacity by blood centres and hospitals to trace donor and patient records, and some donations have been lost to follow-up. Could you explain to us what the issue here was that you were concerned with?
Well, whether you found the patients would depend really on how long the hospitals kept records for and how good the records were. Actually determining that a patient has been transfused in a paper system at that time demanded that the evidence of the donation number was in the patient's notes. And it would appear that some of the hospitals couldn't account for some of the donations sent. So if they didn't have a robust system of recording unused donations, you might lose some.
At which
That's
point?
been very much tightened up in recent times.
At which point a recipient of an infected donation would not be identified by you in the look back?
That's right. Well, or we couldn't. No, not quite. No, there might be donations that hadn't been used, that hadn't been marked up as not used, that weren't determined.
Yes.
You know, it sort of goes both ways.
So it goes both ways. It may be that somebody received it and you weren't able to, the centre wasn't able to identify them. Equally, that particular donation may not have ever been used.
Yes.
But you couldn't say either way.
No, but no.
May I just ask about the first sentence in that particular paragraph? The apparent that the number of implicated donations identified did not correlate with the population served by each centre. Can we have a look at page 6 again, please? No, that's it. Thank you. This is it puzzled me a little when this slide came up, that as to what the purpose of the last of those columns to the right was, the population percent. It's a percentage of the total population of the area, is it?
Yes.
So,
I mean, from my memory, Trent, I think, serves about 5 million. We serve 2.8 million. Greater Northwest, I think, is, I don't know, 4.2, something like that at the time.
But what you're looking at is the number of donations, is it?
Yeah.
Or the number of LBF1 forms. Is the right figure to test percentages against the percentage of the population or the percentage of the donor population? It might depend how someone's going to interpret this information when it gets back to whoever's collating it.
Yes, I mean, but if the information on the AIDS leaflets, for example, which advised donors about high-risk activities, had gone everywhere, and the prevalence in the north was reasonably consistent. You might expect proportional numbers of donations to have been identified.
Yes.
Although it does depend, doesn't it, how many regular donors a centre has as compared to new donors.
Yes, well, that was what I was puzzled about, really. Yeah. What use was going to be made of this? It may be that the assumption was it's pretty much the same proportion across the country, but... Yes, thanks.
Could we just return to page 2 then, please? And if we pick up the third paragraph, it wasn't clear how many patients had been traced but not counselled, either having declined counselling or following advice from their GP. Just in relation to that last point, following advice from their GP, If a GP advised that a person should not be counselled, should not be told that they had received a donation that had been identified as a hepatitis C positive donor, was a note made of that?
It would have been, I had a folder for each person implicated in the look back personally. And I would have recorded all correspondence, including, a letter from the GP that said too old or frail or wouldn't understand or whatever the GP said.
And when a GP said to you, this person shouldn't be counselled, did you take that as, right, then we won't? Or did you probe at all in relation to the reasoning behind their...
Well, they normally said why, and it was normally somebody who... at that stage in their life had no understanding or was terminally ill, I think. That was normally the situation.
So when you were doing the look back in the Liverpool Centre, you had clear notes of when that had happened and why?
Yeah, I had a folder for each one because they were, by that time, effectively, they were a patient because they were, implicated in a possible infection.
And then the final paragraph above the heading of action points, clinical feedback from hepatologists was variable and it was hoped that this would increase. What was your concern here?
Well, in Liverpool, we had written in advance to identify liver specialists in local hospitals, hopefully, because we had covered such a big geographical area, as many centres do. I didn't have the impression that maybe others had, nominated convenient local liver experts for their referrals. And so I did this thing on a referral basis, and as I referred, then I would expect a letter back from the specialist, but it didn't seem as if other colleagues were quite getting the feedback.
You then moved on to become the co-director of the Mersey and North Wales Hemophilia Centre. So is it fair that you didn't then have any particular involvement in any further work of the look back or any decisions about what should be done?
That's right. Once I wasn't working there full time, I handed that on, I think, to Dr. Shepherd.
Okay. In terms of your appointment as a co-director of the Liverpool Hemophilia Centre, can you help us with how you came to that appointment? Because at that point, would it be fair that you hadn't had a significant experience in the clinical role of treating people with haemophilia? It was something of a sideways move.
Yes, I've been involved with it in training, both at Manchester Royal Infirmary, where I worked for a couple of years, and at Pendlebury, at the Children's Hospital in Manchester, where I worked for 4 months. But the opportunity came up, and so I chose to move back into clinical work.
In your statement, you say that at the Liverpool Comprehensive Care Centre, certainly from when you were there, you'd endeavour not to mention HIV on a death certificate of a patient. Yes. Why was that?
My colleague, Professor Toe, and I were very conscious of what people have to do with a death certificate in terms of passing it on for financial details to all sorts of people. And there was, from the middle 1980s, there had been an appalling stigma associated with HIV in the community, perhaps particularly for the poor people with haemophilia. They had trouble both in their neighbourhoods, children at school, and were very sensitive about this. And sometimes, usually their families knew about it, they might not always. And it's important to protect patient confidentiality in death as well as in life. Also, the information in public health terms was known. It was a notifiable disease and would have been notified at diagnosis. The UK Haemophilia Centre Doctors Organisations, UK HCDO, we did a quarterly return of death, so that very sadly these facts would be recorded centrally as well, without the upset for the family, that sort of thing being written on the death certificate.
Had you been given any guidance by anyone in relation to taking that approach to death certificates?
No, only my colleague.
That was a discussion between you and your colleague. Okay. Can I then pick up your appointment as a trustee of the Macfarlane Trust in 2008? We've had the inquiry's heard a lot of evidence about the trust, so I'm only going to pick up a few points from your statement. I've been asked to ask that again, when you were appointed, would it be fair to say your experience with haemophilia patients was relatively limited, and you'd only returned to the clinical setting in 1995? So as a trustee, perhaps your clinical experience of haemophilia patients was not as great as others?
Well, I suppose so, yes. I mean, it was, what was it? 11 or 12 years, yes.
When you were acting as a trustee, were you aware of the need for you to be entirely independent of the Department of Health?
Yes, very much so.
And
although I was appointed by them, but yes.
Well, it's exactly that interaction, Dr. Martlew. Having been appointed by the Department of Health, were you aware of any interference from them in the workings of the trust?
Not exactly interference, but it would have been very helpful if they could have always agreed our revenue budget some weeks or months before the end of the financial year. That was tricky in some years.
And in what way
the chief executive liked to prepare a budget to present to the trustees in good time for the end of the year and the accounts and so on. And on several occasions, I can remember saying, well, this is how we want it to be, on the assumption that we will at least have as much as last year. And then usually reported in April that they, since the January meeting, they'd had the confirmation. But that was a bit difficult.
And you've also said that at meetings of the Macfarlane Trust, the majority of grant applications had a suggested decision for approval by the board.
Yes.
Can you recall who made the suggestions to the board of what the decision should be?
There was a subcommittee when I started that looked through all the grants. I wasn't on this subcommittee, and the majority of them were quite clear to these experienced people, and we usually recommended it or not. And then anything which was a bit more for discussion was discussed at the full board meeting.
So generally, if the subcommittee recommended it, you followed that recommendation?
Oh, yeah.
So I have no further questions for Dr. Martlew, but I'm conscious that there may be some questions from core participants.
Yes.
Might we take a short break?
Yeah, we shall do that. Dr. Martlew, there may well be questions for you from core participants who've been watching remotely, and they have the right to ask counsel to put some questions to you. She will have to field those and think about how she best puts those points to you. That takes a little while. It'll be about half an hour, I would think, would it?
It may be
maybe
less,
longer, or maybe less.
No, maybe less. So
maybe
I would have
less.
said 20 minutes today. If
Right. Okay.
I
In which
received
case,
some over lunch, so
yes. Let's meet again at 20 to 3, if that would suit you. And I can't tell you how long you will then be, but it won't be very long, I suspect. But 20 to 3.
thank you, sir.
Thank you.